Welcome back to this next video in which we are discussing the Renin-Angiotensin-Aldosterone System and the Antidiuretic hormone system. So in this next video, we're now going to actually move on and discuss these two systems, and we're going to begin with the Renin-Angiotensin-Aldosterone System. Before we do begin, however, let me just say that, like with the renal physiology that we discussed earlier on, you can learn the renin-angiotensin-aldosterone system and the antidiuretic hormone system in a huge amount of detail if you so wish. We're not going to do that. We are going to discuss just the big picture of how these systems work and what they achieve, because it's that we need to understand in order to understand the 4 diseases that we want to discuss later on. So we're just going to discuss the big picture of these systems rather than the microscopic details. So let's begin then with the renin-angiotensin-aldosterone system. So firstly then, what is the actual aim of the renin-angiotensin-aldosterone system? So the answer is that the aim is to maintain blood volume, and for short, we will abbreviate blood volume down to BV. So, in contrast, we'll see later that the antidiuretic hormone system is all about maintaining blood osmolarity, the concentration of electrolytes within the blood. So blood volume then, it's very important to maintain blood volume because we don't want blood volume to go too high because otherwise the blood vessels are going to burst open, and neither do we want it to go too low because then we won't have enough blood to actually deliver enough oxygen to the tissues of the body. So we need to maintain blood volume at a certain nice set point, a certain rough set point, and that's what the aim of the renin-angiotensin-aldosterone system is. Of course, we also know that on a daily basis we are consuming food and water, and these will be absorbed by the intestines and will change the volume of the blood. So depending on how much we eat, we're going to have different changes in the actual blood volume, and we need to have a system that can actually tackle this and can adapt to this and can alter the amount of urine that is being produced by the kidneys in order to restore blood volume to the ideal set level that we want to maintain it at. So that's the aim of the renin-angiotensin-aldosterone system, to maintain blood volume. The next question is, how do the kidneys actually know what blood volume is? Because the renin-angiotensin-aldosterone system, as we will see, it starts off at the kidneys, and it's the kidneys that are going to measure what blood volume is. So how do they actually do it? Well, they do it in quite a clever way. They infer what blood volume is by looking at the amount of blood that they are receiving. So they look at renal blood flow. And from renal blood flow, they can infer what is happening to blood volume, and therefore they use renal blood flow to determine how active they want the renin-angiotensin-aldosterone system to be. So, at this point I should say that you can learn, if you want, the mechanism by which the kidneys actually measure renal blood flow in a huge amount of detail. We are not going to do that. We are just going to say that the kidneys are capable of measuring renal blood flow, and they use renal blood flow to decide how active the renin-angiotensin-aldosterone system is going to be. What I do want to justify to you is why looking at renal blood flow is actually useful in inferring what is happening to blood volume. And this has to do with a fancy rule from cardiology, which is named after a very famous physiologist called Starling. And this is Starling's law. So I'll just remind you of what Starling's law says. So Starling's law says that if you increase the volume of blood that is in the heart before the heart contracts, then the heart muscle will contract harder than it would have if there was a smaller volume of blood in the heart. And that will result in the amount of blood that is actually ejected from the heart, the stroke volume of the heart, being increased. That is what Starling's law says. Now, if blood volume changes, let's say blood volume goes up, what is going to happen is all of the blood vessels are now going to have more blood in, and they're all going to be stretched more, and that includes the heart. The heart is now going to have more blood in if you've increased blood volume. And then we use Starling's law, which says that if the heart has a greater volume of blood in, then the stretch on the wall of the heart is greater, and that means that the actual myocardium, the cardiomyocytes that make up the walls of the heart, are going to contract more forcibly. They're going to exert a greater force, and that means that you've got more energy to exert on the blood, and you're going to eject a larger volume of blood. So, what this means is that when blood volume goes up, the stroke volume of the heart is also going to go up. So, let's say blood volume is going to change stroke volume, which I'll abbreviate to SV, which is then going to influence cardiac output. So remember, cardiac output, CO, this is simply a term that means the amount of blood that is pumped from the venous system to the arterial system by the heart in a minute. So cardiac output is quite simply stroke volume, the amount of blood ejected by the heart every time it beats, times heart rate, the amount of times the heart beats in a minute. And of course, cardiac output is then going to affect renal blood flow, because about a quarter of the cardiac output goes to the kidneys. So if cardiac output changes, renal blood flow is going to change. So this is effectively the story of how blood volume influences renal blood flow. Blood volume is going to increase, is going to alter stroke volume. Of course, if blood volume goes down, stroke volume will go down, but if blood volume goes up, stroke volume will go up. So blood volume changes stroke volume by this fancy law from cardiology, Starling's law. Stroke volume going up means that cardiac output will go up, and that means that the blood flow to the kidneys, the renal blood flow, is going to go up or down depending on what blood volume is doing. So that is the justification for why blood volume affects renal blood flow, and therefore by looking at the amount of blood that they are receiving, the kidneys can infer what is happening to the blood volume. So to spell this out crystal clear, if renal blood flow goes up, the kidneys say that means blood volume is high. If renal blood flow goes down, the kidneys say that means that blood volume is low. If renal blood flow is perfectly normal, that means that the kidneys say blood volume is perfect. That is how they work out what is happening to blood volume, and that's how they determine how active they are going to make the renin-angiotensin-aldosterone system. So we'll come back to this later on. Now what I want to do is actually discuss the different components of the renin-angiotensin-aldosterone system, and then we'll come back and link it up to this concept of blood volume and renal blood flow. So, the renin-angiotensin-aldosterone system, it's quite a nice name because it tells you the different components of the system. So the first part of the renin-angiotensin-aldosterone system is renin, which is an enzyme produced by kidney tissue. And it's an enzyme that kidney tissue can release into the blood. So the kidneys release renin into the blood, and it's the start of the renin-angiotensin-aldosterone system. And as we'll see, they determine how much renin they're going to be releasing by what is happening with renal blood flow, which of course corresponds to what's happening to blood volume. So renin is an enzyme that's going to be released by the kidneys into the bloodstream. It's the first part of the renin-angiotensin-aldosterone system. What does renin do once it's in the bloodstream? Well, it converts a protein that is in the blood called angiotensinogen, which is a protein that is put into the blood by the liver. So it's a big name, angiotensinogen. So this is the precursor to angiotensin, and it's secreted into the bloodstream by the liver. So you have lots of angiotensinogen in your bloodstream waiting to be converted by renin enzymes secreted by the kidneys into angiotensin. So what does renin convert it into? It converts it into angiotensin 1. Angiotensin 1 is not particularly active. To make it into the active form, it needs to be converted into angiotensin 2, and this is carried out by an enzyme called angiotensin converting enzyme, which is called ACE for short. So angiotensin 1 is converted into angiotensin 2 by the enzyme angiotensin converting enzyme, or ACE for short. Now, where does the enzyme ACE come from? So ACE is actually always active, and it's on the surface of endothelial cells. So endothelial cells line all of the blood vessels of your bodies. They line arteries, they line capillaries, they line veins. And on the surface of the endothelial cells that faces into the lumen of the blood vessels are proteins that the endothelial cell has put on its surface. One of those proteins is this enzyme, angiotensin-converting enzyme, particularly in the capillaries of the lungs, the pulmonary capillaries. There is a particularly high presence of angiotensin-converting enzyme on the surface of those endothelial cells. But in fact, all over the vascular system, the endothelial cells do have some ACE, but it's particularly highly present in the pulmonary capillaries. So, the message from that is that angiotensin-converting enzyme is all over the place in the vascular system, and therefore the angiotensin 1 that is in the blood plasma can easily then be converted into angiotensin 2. Angiotensin 2 is then going to activate the release of aldosterone from the adrenal glands. So let's just talk about the anatomy of the adrenal glands very basically. So the adrenal glands sit above the kidneys. You have one on either side, just as you have two kidneys. And their anatomy is again split into two layers. It's split into the adrenal cortex and the adrenal medulla. So let's just draw a little picture of an adrenal gland. What colour should we have it? We'll have it in yellow. So they look roughly like this, and you'd have the kidney sat underneath here. So we split the adrenal gland then into these two major parts. This is the adrenal medulla and this is the adrenal cortex. The adrenal medulla is responsible for the secretion of adrenaline, hence the name. The adrenaline is named after the adrenal glands from which it's secreted. So adrenaline comes from the adrenal medulla. The adrenal cortex is more complicated. It's split up into 3 different layers. So if I zoom in on the adrenal cortex, let's say this is a piece of adrenal cortex, we split it up into 3 different layers. And the layer that we care about is the outer layer, which is called zona glomerulosa. This is the layer which contains secretory cells that produce aldosterone. So I'll just have a little cell here. So that represents one of the cells of the zona glomerulosa. The other layers, the middle layer is called zona fasciculata and the bottom layer is called zona reticularis. Zona fasciculata produces the glucocorticoid cortisol, whilst the zona reticularis produces androgens after puberty. So androstenedione and dehydroepiandrosterone are the 2 major androgens secreted by the zona reticularis, and they are responsible for producing secondary sex characteristics in both men and girls. So they produce, for instance, underarm hair and pubic hair. In both boys and girls. Of course, in boys, you additionally have the testes secreting testosterone, which means that boys get a lot more hair, so facial hair and hair on the arms and legs as well, and more muscle and a deeper voice. But importantly, girls have androgens too, and they come from the zona reticularis here. But we don't actually care about those 2 layers. The layer that we care about is the zona glomerulosa, the outer layer of the adrenal cortex. This represents a zona glomerulosa cell, and angiotensin 2 works on the cells of the zona glomerulosa and causes them to secrete aldosterone. So they release aldosterone. So this is a great big chain reaction, basically. It starts with renin, which kickstarts the whole thing, converting angiotensinogen into angiotensin 1. Angiotensin 1 is then converted into angiotensin 2, and angiotensin 2 causes the release of aldosterone, and aldosterone is now going to go and have effects back on the kidney. So the whole thing starts with the kidneys, then it becomes something that happens in the vascular system, then it goes to the adrenal glands, and now finally aldosterone is going to come back to the kidneys, and it's actually going to have an effect on the nephrons. So it is going to change the amount of urine you are actually producing. It's going to determine the amount of the glomerular filtrate that actually becomes urine. So you remember what we said previously when we were discussing renal physiology, that we are producing glomerular filtrate in the 2.4 million nephrons that we have in the kidneys. And to have a nice number, we've said that the glomerular filtration rate is roughly 100 milliliters per minute. So we're producing 100 milliliters of glomerular filtrate every minute. We then said that most of this is all going to be resorbed along with the electrolytes that it contains. About 1 milliliter is then going to actually be used to make urine, and all of the metabolic waste products from the whole 100 milliliters is going to be concentrated down into that 1 milliliter, and that's going to become the urine. And of course, we also discussed how, of course, we're going to resorb the useful molecules from our glomerular filtrate, like glucose, amino acids, and any proteins there will take them back up. Now, aldosterone is going to influence the actual volume of fluid that we're actually going to make into urine. It's going to influence the fraction of the glomerular filtrate that we actually make into urine. So this was the archetypal example that we take 1 milliliter out of the 100 milliliters, i.e. 1% of the fluid, and actually make that into urine. But this is changeable. We can make it bigger. We could make it 3 milliliters. We could make it 3%, or we could make it smaller. We could take it down to half a milliliter, or maybe even a quarter of a milliliter. And the control of this this fraction of the glomerular filtrate that is going to become actual urine is under the influence of aldosterone. So let's now that we've discussed this stuff, put it all together to make a full picture. So, renal blood flow is going to determine how much renin the kidneys release into the bloodstream. And of course, the kidneys are using renal blood flow to infer what is happening to blood volume. So the whole thing is going to be controlled by blood volume. So, the whole system has a basal function. So let's say that blood volume is perfect. Blood volume is absolutely fine, so it's not too high, it's not too low. What is the activity of the renin-angiotensin-aldosterone system in that case? So if everything's going fine, there's a nice normal renal blood flow, and the kidneys will release a basal amount of renin. So it's not the case that they don't release any renin where everything's fine. No, they release a basal amount of renin. This will result, through this pathway that we've discussed, in a basal secretion of aldosterone. So the zona glomerulosa will secrete a certain amount of aldosterone, which is the basal level, the normal level of aldosterone to have in your bloodstream, which reflects that blood volume is perfect. This aldosterone will then go to all of the nephrons of the kidneys, and it will tell them that they should be making this normal fraction of the glomerular filtrate into urine. So it will tell them, yes, we should be making 1 milliliter out of the 100 milliliters of the glomerular filtrate actually into urine. So when aldosterone is at the basal level, all of the nephrons will make the normal fraction of the glomerular filtrate actually into urine, i.e. 1 milliliter. Now, let's say blood volume goes too high. How is this going to change? So if blood volume goes too high, renal blood flow is going to go too high, and that causes the kidney to reduce the amount of renin it secretes, okay? So actually, we can say that renal blood flow going up actually inhibits the release of renin. Renin goes up when renal blood flow goes too low. So the whole system is turned down from its basal level if renal blood flow goes too high. So renin goes down. That means that the conversion of angiotensinogen to angiotensin 1 and then the formation of angiotensin 2 is going to go down. And by the way, the half-life of these things is very short, so this system can adapt very quickly. So angiotensin 2 is going to go down, aldosterone is then going to go down. So the aldosterone level is going to be at a lower level than its basal level when our blood volume goes up. When aldosterone goes down, what that is going to tell all of the 2.4 million nephrons in our kidneys to do is it's going to tell them to make a larger fraction of the glomerular filtrate into urine. So it will now say, hang on, we've got too much blood volume, hence why aldosterone has gone down. So what we now need to do is we need to make more urine. So instead of just making 1% of the glomerular filtrate into urine, let's now make 3% maybe into urine. So let's make 3 milliliters of the 100 milliliters of the glomerular filtrate into urine. So let's make more urine. And of course, this fluid that we're going to secrete will have all the electrolytes in it, so it'll be water plus the electrolytes, and we'll now be concentrating all of our waste products from the whole glomerular filtrate into 3 millilitres rather than 1 milliliter, so we'll be producing more dilute urine. But this is helpful because our blood volume is too high and we want to bring it down. So by producing more urine, we're going to help bring our blood volume down. So that's what happens if blood volume goes too high. Let's finally talk about what happens if blood volume goes too low. So if blood volume goes too low, renal blood flow is going to go down, and the kidneys do not like that. So what they will then do is they will activate the renin-angiotensin-aldosterone system. So renin will go up, and it will be released at a higher rate than it would have at that basal level when blood volume is fine. Renin going up will overall, through all of this, lead to aldosterone level going up. So aldosterone in the blood will go up in response to blood volume being too low. And aldosterone then goes to the nephrons of the kidneys, and the nephrons interpret that signal to mean, oh dear, blood volume is too low, we now need to conserve fluid. So we're going to have to make extremely concentrated urine. We were previously at this basal level, making 1% of the glomerular filtrate into urine. We need to make that smaller. We need to maybe go down to half a milliliter of the 100 milliliters actually becoming urine, i.e. 0.5%. So we need to make our actual urine volume smaller. And that's what happens in response to aldosterone going up. And that means that we will then be conserving more water with the electrolytes in it, and therefore will be helping to conserve our blood volume and not let it go any lower until we can find some food and water to actually top up our blood volume level. So that's how the renin-angiotensin-aldosterone system responds to blood volume going too low. So overall, what we have seen is that this system is designed to help maintain blood volume as much as possible. When blood volume is at a normal level, the system is not completely off. Instead, it's working at a basal level, and the basal amount of aldosterone that produces, and which is in the blood, will tell the kidneys that they can function as they normally would at their basal level and produce about 1% of the glomerular filtrate as urine. Whereas if blood volume goes too high, aldosterone will go down, and that will tell the kidneys that actually now they can make a larger fraction of the glomerular filtrate along with its electrolytes into urine. So they'll make more dilute urine. If blood volume goes too low this time, aldosterone will go right up, the renin-angiotensin-aldosterone system will be activated, and that will tell the nephrons of the kidney that they need to now make the urine extremely concentrated. They need to conserve as much water and electrolytes as possible, and they need to make a very small fraction of the glomerular filtrate actually into urine. Okay, so that is the renin-angiotensin-aldosterone system. Next, let's move on to the antidiuretic hormone system. And because I haven't actually written out its name in full yet, that's where we'll start. So we'll talk about the antidiuretic hormone system, which is what ADH stands for, antidiuretic hormone. It has another name, which you should be aware of, which is vasopressin. So it's also called vasopressin. So, the renin-angiotensin-aldosterone system was all about maintaining blood volume. The antidiuretic hormone system is all about maintaining blood osmolarity, which means the concentration of the dissolved electrolytes within the blood. Now, if you drink water, so let's say you're not eating a meal, instead you're going to drink water, what is going to happen is that water does not contain the right concentrations of electrolytes that your blood contains. So when you drink a glass of water, that water is going to be absorbed by the gastrointestinal tract and is going to increase blood volume, but it is also going to alter blood osmolarity. It's going to make all the concentrations of the electrolytes lower. Contrast that to what happens if you have a drink whilst eating a meal. So if you eat a meal, that will contain electrolytes. It'll have sodium, potassium, chloride in there. You'll have electrolytes in a meal. And then when the intestine absorbs water from the drink that you had with the meal, it'll also absorb electrolytes. So in that case, your blood volume is going to increase, but you're also going to get more electrolytes, and therefore you're going to get more fluid with electrolytes in, and hopefully your osmolarity will not change too much. So that was a scenario that would just activate the renin-angiotensin-aldosterone system, because in that case, osmolarity isn't the problem, it's just blood volume that has gone up that is the problem. Whereas, if we just have a drink of water, that's going to increase our blood volume, so it's a problem for the renin-angiotensin-aldosterone system, but it's also going to alter our blood osmolarity, and therefore it's a problem for the antidiuretic hormone system as well. So in the case where you drink a glass of water and you're increasing blood volume but also decreasing blood osmolarity, that's when you need the antidiuretic hormone system activated as well as the renin-angiotensin-aldosterone system. So this is all about blood osmolarity. So let's talk about the basic structure of the system, like we did with the renin-angiotensin-aldosterone system. So unlike the renin-angiotensin-aldosterone system, where it started off in the kidneys, the antidiuretic hormone system is going to start up in a much more fancy organ. It's going to start up in the brain. So let's get a nice colour for the brain. Let's go back to our yellow colour. So here is a basic picture of the brain. So here is the left cerebral hemisphere viewed from the left-hand side. There we have the pons and the medulla, and then the cerebellum at the back. So, antidiuretic hormone is going to be secreted by the posterior pituitary gland. So I'll just draw the pituitary gland a little bit out of scale, dangling down from there. So remember, the pituitary gland is split into the anterior pituitary gland, which secretes things like growth hormone, the gonadotropins, follicle-stimulating hormone, and luteinizing hormone. It secretes thyroid-stimulating hormone, adrenocorticotropic hormone, and also prolactin. The posterior pituitary secretes antidiuretic hormone, vasopressin, and also oxytocin. So the posterior pituitary is going to be the important one to us. It's going to secrete antidiuretic hormone, ADH, into the bloodstream. And it's going to do this in response to changes in blood osmolarity that are measured by certain nuclei up in the hypothalamus. So blood osmolarity is going to be monitored by certain nuclei up in the hypothalamus, and when they notice changes in blood osmolarity, they're going to change the amount of antidiuretic hormone that is being secreted by the posterior pituitary. So let me just label up the important gland in the antidiuretic hormone system is the posterior pituitary gland. So now let's talk about the effect of antidiuretic hormone on the kidneys. So like aldosterone, antidiuretic hormone is going to go down to the kidneys and it's going to act on all of the 2.4 million nephrons that you have within the kidneys. And the effect that antidiuretic hormone has is to change the concentration of electrolytes in the actual fraction of the glomerular filtrate that is actually going to become urine. So let's go back up to this picture. So the renin-angiotensin-aldosterone system, it changed the fraction of the glomerular filtrate that is actually going to become urine. What the antidiuretic hormone system is going to do, what antidiuretic hormone is going to do, is it's going to alter in the little fraction of glomerular filtrate that actually becomes urine, what is the concentration of electrolytes that is actually going to be in there. And when antidiuretic hormone goes up, it's going to result in a higher concentration of electrolytes. It's going to make all the electrolytes that we discussed here be in higher concentrations in that fraction that's going to become urine. And when it goes down, that's when it's going to make the concentrations of the electrolytes in the fraction of the glomerular filtrate that's actually going to become the urine lower. So let me explain this and put it all together. And again, we'll have the three scenarios like we had with the renin-angiotensin-aldosterone system. So we'll start with the basal scenario. The basal scenario is that blood osmolarity is perfect, okay? So the concentration of sodium, potassium, chloride, and bicarbonate in the blood is absolutely perfect. There's nothing wrong with blood osmolarity. In that case, the hypothalamus will be telling the posterior pituitary to release the basal amount of antidiuretic hormone, the steady level of antidiuretic hormone. So you're releasing a normal amount of antidiuretic hormone. That antidiuretic hormone will go down to the kidneys and it will influence the nephrons and it will tell the nephrons osmolarity is absolutely fine. So with regards to the urine that you're producing, just put in the normal amount of electrolytes, i.e. put in these concentrations of the electrolytes, because if you do that, then the osmolarity of the rest of the fluid that is remaining in the bloodstream is not going to be altered, because we're secreting the right amount, well, we are excreting the same concentrations of electrolytes in our urine as we had in our blood plasma. So it will basically tell the nephrons to just leave the concentration of the electrolytes in the fraction of the glomerular filtrate that's going to become urine alone. Leave them be. You don't need to change them at all. That's what happens with the steady level of antidiuretic hormone. And I would just like to have an arrow going all the way round like this. So antidiuretic hormone is going to be influencing the nephrons over here. Okay, so that's what the steady level of antidiuretic hormone is going to do. Now let's imagine that blood osmolarity goes up. So the electrolytes all become too concentrated. What is then going to happen? In that case, antidiuretic hormone release is going to go up. So the hypothalamus is going to tell the posterior pituitary to release more antidiuretic hormone, and the level of antidiuretic hormone in the bloodstream is going to go up beyond the normal set point, the normal basal level of antidiuretic hormone. That's going to go down to the nephrons, and what it's going to tell the nephrons to do is it will say, blood osmolarity is now too high. What we need to do is we need to excrete more electrolytes in our urine so that we're getting rid of electrolytes so that we can bring down blood osmolarity. So the effect of antidiuretic hormone on the nephrons, and I want to stress something here, you can go away and learn the mechanisms by which aldosterone and antidiuretic hormone actually act on nephrons, and if you do that, you will become a little bit confused, because if you learn the microscopic mechanisms by which they work, you'll find out that aldosterone actually achieves control over the amount of fluid that you're secreting in the urine by changing the amount of electrolytes that you're excreting in the urine, and you'll find that antidiuretic hormone actually changes the concentration of the electrolytes in the urine by maneuvering with water. So it seems the opposite way round to the actual big picture. So just to warn people who do actually know the microscopic details that it seems a little bit counterintuitive, but when you actually study the big picture of what these hormones do, you'll realize that despite what they do microscopically, this is what they do macroscopically. So that's just a warning for people who do know the microscopic details of how aldosterone and antidiuretic hormone influence the nephrons, to just think about it carefully and realize that the big picture is what I am telling you. Don't get confused by it. Okay, so back to what I was discussing. So if osmolarity goes up, the hypothalamus is going to tell the posterior pituitary to increase the amount of ADH that it's secreting from the basal level, and ADH is going to act on the nephrons, and it's going to tell the nephrons that they need to make the concentration of the electrolytes in the fraction of the glomerular filtrate that is going to become urine higher. And that way we're going to excrete more electrolytes, and we're going to hopefully tackle the problem with osmolarity. So what I'm saying is that whatever volume of urine you're actually producing, whatever fraction of glomerular filtrate that becomes urine that you're producing, which is set by the Renin-Angiotensin-Aldosterone System, the antidiuretic hormone is going to influence the concentration of electrolytes in that. And if antidiuretic hormone goes up, the concentration of electrolytes in that is going to be raised beyond the basal level, which is these levels that are the same as the plasma levels of those electrolytes. And then let's go over the final scenario. So if blood osmolarity goes too low, which is, you can imagine, something that we face every day, because when we drink a glass of water, that's going to reduce our blood osmolarity. So if osmolarity goes too low, that's going to be detected by the hypothalamus. The hypothalamus will tell the posterior pituitary to decrease the amount of antidiuretic hormone it's secreting below the basal level, and a decrease in the antidiuretic hormone in the blood is going to tell the nephrons down in the kidneys that blood osmolarity is too low, and what they now need to do is take up more of the electrolytes from the fraction of the glomerular filtrate that's going to become urine, so that the concentration of the electrolytes in that bit of urine is going to be below the levels of plasma here. And then, of course, we will get to maintain those electrolytes, and that will help bring blood osmolarity up. And just to make it absolutely clear, what I was saying earlier, warning people about the microscopic mechanisms, that might become clearer now after what I've just said for those who do know the microscopic mechanisms and know that actually antidiuretic hormone doesn't affect the reuptake of the electrolytes directly. It actually affects the reuptake of water, whereas the aldosterone actually affects the reuptake of electrolytes. But actually, when you think about the bigger picture, it is slightly counterintuitive, and it ends up being the case that antidiuretic hormone more alters the concentration of the electrolytes in the urine, whilst the Renin-Angiotensin-Aldosterone system monitors the absolute volume of it. Okay, so just think about it very carefully if you know the microscopic mechanisms. If you don't know the microscopic mechanisms, be happy with the big picture that I'm telling you here. So, let's just summarize what we have said so far. And in particular, I want to talk about the scenario where you drink a glass of water again. So, if you drink a glass of water, both systems are going to be activated because blood volume is going to go up, but also blood osmolarity is going to go down. So blood volume going up is going to decrease the activity of the renin-angiotensin-aldosterone system, which is going to tell the kidneys to make a larger fraction of the glomerular filtrate into urine, and therefore is going to increase the volume of urine. Meanwhile, antidiuretic hormone system is also going to be inhibited by blood osmolarity going down, and it's going to tell the nephrons that in that larger volume of glomerular filtrate that's going to now become urine, we want the concentration of the electrolytes to be lower than in plasma. So it will lower the concentration of the electrolytes in that urine and will conserve the electrolytes effectively, helping to bring up blood osmolarity. Whereas, if you eat a meal and have a drink with that meal, in that case, we can imagine that blood volume will go up, but you're also getting lots of electrolytes from the meal, and therefore you might not get osmolarity changing, you'll just get blood volume changing, and in that case it will just be a job for the renin-angiotensin-aldosterone system. So what I'm trying to point out is that in different scenarios, both of them might be altered, whereas in other scenarios, it might just be one that's becoming active. So, in summary then, the renin-angiotensin-aldosterone system, the big picture is that it affects the volume of urine that you're going to produce, and it does this to try and help maintain blood volume. The antidiuretic hormone system, it monitors blood osmolarity, and it effectively, although not directly if you actually know the microscopic mechanisms, but effectively overall, the big picture is that it alters the electrolyte concentration in the urine, and thereby alters or helps to maintain and correct the blood osmolarity and maintain it at a certain set point that we want it to be. So, we will have a break here, and in the next video what we'll do is discuss the 4 diseases that involve these two systems, and we'll try and understand what happens in those diseases.